Welcome to Medicine Handy Point. Today we will discuss a very tough topic, which is nephritic syndrome, but I try my best to make it simple, so let's discuss this. Now, nephritic syndrome has 5 features, so let's discuss one by one. Number 1, there will be glomerular hematuria. Number 2, there will be subnephrotic range proteinuria, means ranging from 1 to 3 gram per day. There will be edema because there is loss of protein. There will be hypertension and there will be rising creatinine. So these 5 features will be present in the nephritic syndrome. So what are the causes for the nephritic syndromes? Number 1 is post-infectious glomerulonephritis, IgA nephropathy, Henoch-Schönlein purpura, HSP, GN, PASI immune, GN, anti-GBM, GN, which is actually called good posture syndrome. GBM means glomerular basement membrane antibodies associated glomerulonephritis. Then there is membranoproliferative glomerulonephritis and C3 glomerulopathies. Then there is hepatitis C virus associated kidney injuries, and lastly there is SLE associated kidney injuries leading to glomerulonephritis. So let's discuss each one of these 8 types one by one. Post-infectious glomerulonephritis usually starts 1 to 3 weeks after the pharyngitis. Usually pharyngitis will be caused by group A streptococcus, or there will be skin infection in the form of impetigo, or during the course of pneumonia or infective endocarditis there will be this post-infectious glomerulonephritis, but mostly it is after pharyngitis and 1 to 3 weeks after the pharyngitis. Urinary will show hematuria as usually occur in nephritic syndrome and proteinuria. Blood tests will show low serum complement level, means low C3 and C4, and raised ASO titers. Renal biopsy will show, renal biopsy has 3 portions. Light microscopy will shows diffuse proliferation, means a lot of cells in the glomerulus apparatus. Immunofluorescence will show IgG and 3 deposit in mesenterium and along the capillary basement membrane. So immunofluorescence actually shows us the antibodies and complements. And then the last part of renal biopsy testing is electron microscopy, which will show dense deposits along the epithelial basement membrane. Treatment is usually general treatment of any kind of nephritic syndrome is salt restriction, antihypertensive, mostly ACE inhibitor or A or B, diuretic for edema. Specific treatment includes treat the infection effectively. If there is pharyngitis, effectively treated, impetigo treated. So, and steroids has no established role, but mostly given by nephrologist. And children recovers, while adult may progress to rapidly progressive glomerulonephritis and CKD. Now let's discuss IgA nephropathy. In IgA nephropathy, classic presentation is upper respiratory infection. Then after 1 to 2 days there will be gross hematuria. No specific blood tests, renal biopsy, light microscopy will show focal glomerulonephritis, and immunofluorescence will show diffuse IgA and C3 deposit in the mesenterium. So that will be the picture in the IgA nephropathy. Treatment, just like we discussed earlier, there is general treatment, hypertension control, salt restriction, and diuretic for edema. A specific treatment, steroid has no established role, and in case if there is rapidly progressive glomerulonephritis with crescent formation, then steroids and cyclophosphamide can be tried. If the patient develop end-stage renal disease, then renal transplant, but recurrence occur in the transplanted kidneys. Now let's discuss enoxazoline purpura. There is usually upper respiratory tract infection followed by pulmonary purpura, arthritis, and abdominal pain. Urine will show hematuria and proteinuria, and renal biopsy shows same picture as of IgA nephropathy. It usually resolves by itself, and those who develop rapidly progressive glomerulonephritis, pulse steroids and cyclophosphamide along with plasma exchange to remove the IgA antibodies can be tried. Difference between the enoxazoline purpura and IgA nephropathies is in enoxazoline purpura there will be palpable purpura on the skin, arthritis, and abdominal pain. Now let's discuss pauci-immune glomerulonephritis, which is ANCA-associated glomerulonephritis. So usually this kind of glomerulonephritis occurs with small vessel vasculitis like granulomatosis with polyangiitis, which is the new name for Wagner granulomatosis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis, which is the new name for Church-Strauss syndrome. In serum, ANCA subtypes like antiproteinase 3 antibodies and myeloperoxidase type of ANCA antibodies are measured. Wagner granulomatosis, which is granulomatosis with polyangiitis, actually shows PR3, which is antiproteinase 3 ANCA-associated antibodies, while microscopic polyangiitis will show MPO, which is myeloperoxidase associated ANCA subtype of antibodies. These will be present in microscopic polyangiitis. Now, renal biopsy will show necrotizing lesions, while immunofluorescence will show no immune complex deposition. That's why it is called pauci-immune glomerulonephritis. Treatment usually pulse steroid with cyclophosphamide along with plasma exchange to remove the antibodies is done. Now let's discuss anti-glomerular basement membrane glomerulonephritis, which is also called Good-Pasha syndrome. There will be hemoptysis and dyspnea. Along with that, there will be hematuria. Diagnosis: the chest X-ray will show pulmonary infiltrate. Serum complement levels are normal because there are other antibody generation which are anti-basement membrane antibodies, which will be present in 90% of the cases. Renal biopsy will show crescent formation and the renal biopsy light microscopy will show crescent formation, while immunofluorescence will show linear deposit of IgG immunoglobulin along basement membrane. Now, treatment is actually plasma exchange is done daily for 2 weeks along with steroid and cyclophosphamide to prevent formation of new antibodies. Now let's discuss membranoproliferative glomerulonephritis and C3 glomerulopathies. Actually, membranoproliferative GN is a chronic process. These two problems are grouped together because light microscopy and electron microscopy are similar, but immunofluorescence microscopy provides the differentiating features. So let's discuss that. Membranoproliferative GN is due to chronic antigenic response, mostly chronic infection like hepatitis C virus, chronic parasitic infection like chronic malaria, and chronic bacterial infection, it leads to membrane proliferative glomerulonephritis or a paraproteinemia. Chronic process, autoimmune disease like SLE. So, and C3 glomerulonephritis occurs due to dysregulated stimulation of the complement factor system. C3 is activated, leading to podocyte and endothelial damage. So, actually, the dysregulated activation of the complement system, usually C3, which leads to then damage in the glomerular apparatus. Renal biopsy light microscopy will show mesangial proliferation with endocapillary proliferation with capillary wall remodeling, because it's chronic process, so there will be capillary wall remodeling resulting in double contour of glomerular basement membrane. Tramtech appearance, typical term for that. Immunofluorescence will show C3 and IgG deposit in membrane proliferative glomerulonephritis, while there will be just C3 deposit in the C3 glomerulopathies, and there will be no immunoglobulin deposit in C3GN. So that is the differentiating point. Electron microscopy will show subepithelial deposits. There is a type of membrane proliferative glomerulonephritis where electron microscopy shows ribbon-like dense deposit, which is called dense deposit disease, and it is usually grouped with C3 glomerulonephritis, and this dense deposit disease along with C3 glomerulonephritis are combinedly called as C3 glomerulopathies. Treatment is identifying the underlying cause is the basis of the treatment. Where there is no cause and disease is severe, then steroid plus cyclophosphamide is used. Renal transplant in end-stage renal disease may have recurrence of the disease. Now, HCV, exudative kidney disease. HCV involves the kidneys in three waves. First is it causes membrane proliferative glomerulonephritis, as we discussed earlier. There will be cryoglobulin production in HCV patient. It causes GN, glomerulonephritis, and HCV also causes membranous nephropathy. So this is how HCV affect the kidneys in three different ways. SLE is associated with kidney injuries, causes GN. Renal involvement occur in up to 90% of the cases. So let's classify the renal involvement. There are 6 types of renal involvement. These are type 1 is called minimal mesangial nephritis. Type 2 is called mesangial proliferative nephritis. Type 3 is called focal proliferative nephritis. Type 4 is called diffuse proliferative nephritis. Type 5 is called membranous nephropathy, and type 6 is called advanced sclerosis. Now let's discuss the treatment. In many type 1 there is no treatment. In type 2 again no treatment, and type 6 no treatment, while type 3 and type 4 are mostly treated the same way by induction with pulse steroid methylprednisolone 1 to almost 1 gram IV OD for 3 days, followed by maintenance dose. Along with that, we give cyclophosphamide or MMF. MMF is mycophenolate mofetil with MMF maintenance. This type 3 treatment is the same as for type 4. In type 5, we use MMF without rituximab. In type 6, as we discussed, in type 1, 2, and 6, there are no treatment. HCQ should be given to all patients of SLE irrespective of type of nephritis. SLE patient receiving renal transplant can have recurrence of disease, but chances are low. And surprisingly, if the patient SLE features are improving, that's mean that the patient may be developing end-stage renal disease. I hope you like the lecture and it might help you. And please subscribe to the channel. Thank you.